Welcome to Medical Insights with Dr. Thomas Blum. I'm Dr. Blum. Today we had a great conversation with Dr. Amit Mehta, a medical oncologist from North Carolina. Dr. Mehta and I discussed metastatic prostate cancer and the common questions that patients have when they're newly diagnosed. First, we started off talking about what the diagnosis means. We talked about how it is staged. We talked about treatment options, and then finally discussed some of the most common questions that patients have regarding side effects of treatment and how it impacts quality of life. Dr. Mehta has been a practicing hematologist-oncologist who specializes in prostate cancer. He's had quite varied career. He's an author, as well as an expert medical witness, and is a chief medical officer of a food and nutrition-based website for physicians treating patients with cancer. So stay tuned, we have a great episode today. Amit, thank you for joining me today. It's my pleasure to have you and look forward to this episode. So, when a patient comes to see me with metastatic prostate cancer, the first question that they always seem to have is regarding staging and, what exactly does it mean to have metastatic prostate cancer? So, what do you typically tell patients, with these initial discussions?
Yeah, and my pleasure as well. Happy to be here and join the conversation. Firstly, I always tell patients just to let them sort of know that this is something that we're used to dealing with, being the most common cancer in men in the United States. So it's the most common cancer in general for men. So that sometimes gives people, I think, a little bit of sense of security that we know how to deal with this. We're very experienced. Doctors, oncologists across the country have a lot of patients, collectively that we've seen. So some reassurance that, hey, we've been there before, we've done it, and you're not the first person to come through the clinic, of course, with metastatic prostate cancer. So I kind of just to kind of allay their concerns a little bit and their level of fear a little bit, hopefully by starting with that and just sharing, yeah, I may have experienced treating patients, but this is a common malignancy, common cancer type, and we can do it, we can deal with it. So even if it may be very serious, so that's the first thing. And the second thing, just very generally with metastatic disease, as I'm sure any oncologist will, of course, say, is that unfortunately with metastatic disease, that means that the cancer has spread out of its original organ and gone elsewhere in the body and caused a tumor to form elsewhere in the patient's body. So whether it be a lymph node, a bone, somewhere, that basic understanding that will, of course, explain to patients that when we say metastatic, what we mean is that it's gone outside of the original organ into other parts of the body, unfortunately, therefore making it so-called quote unquote metastatic or much more serious in its nature of how the cancer spread outside the original site of where it developed.
And a lot of patients will come to us from the urologist with this diagnosis. Most of the time, as a medical oncologist, we're not making the diagnosis. So, when patients have their CT scans, their bone scan, which are typically the things that the urologist will have ordered, how confident, can you be when the radiologist reports that there's enlarged lymph nodes, that there's lesions in a bone? And, what are the kind of things that can be done to help solidify the diagnosis? What if there's inaccuracies in the scans, or what if there's ambiguity in the way that they're being read, which often there is?
Yeah, no, I totally agree that this can vary a lot as far as how a scan may be read, and not every lesion or abnormality on a scan is necessarily cancerous or even part of the cancer at all. So I've seen some cases, I'm sure you have, of course, over the years as well, that something is suspicious for metastatic disease. So they find on like a scan done by the urologist, for example, or the primary care physician, that there's some spot on one of the bones. So I will selectively, depending on my impression about the case and all that, I might tell a patient that, hey, by the way, we see something on a scan. We're a little bit worried that this could be evidence of the cancer having spread from the prostate now somewhere else in the body. So we recommend a biopsy of this, and a biopsy will mean that we're going to have one of our medical colleagues use a needle to get a sample of cells from that spot, that bone, and then have the pathologist study it under a microscope and find out, is it or is it not cancerous? So I've seen some cases that have been false alarms. I mean, unfortunately, more often I would say I've seen cases that are not false alarms and are cancerous, but every so often there's a case where there's a PET scan abnormality and it turns out to be a red flag, red herring, I should say, and just a false alarm. It turns out to be negative. But as you say, Tom, there can be some ambiguity as far as how a scan is read. Just because a lesion shows up, it's not necessarily cancer. And just to share a quick anecdote is that I had a patient just a few weeks ago that done regular scan done as part of a restaging of the patient's cancer, reevaluation of the patient's cancer by PET scan. The patient had been on treatment for a while, and 3 separate abnormalities showed up, none of which were related to prostate cancer, but there were other medical things going on, but not cancer connected. And that also is one of these things that patients will, I mean, any patient understandably will right away jump to say, oh my gosh, there are 3 new things showing up. It must be bad. And this is where I would tell any patient out there listening that talk to your oncologist. They'll put it together as far as interpreting, well, is this abnormality related to cancer? Do we need to worry about it at all? Do we need some other workup done? But every abnormality is not necessarily cancer connected.
Yeah, yeah. I mean, there's no doubt. I agree. Pathology is the gold standard amongst oncologists. If we can get a tissue diagnosis, it confirms better than any other modality. One thing I will say, though, is that for patients that come with a PET scan with multiple abnormalities, I was counseling that if we see multiple areas that are worrisome, if we biopsy one of them, usually it will confirm what each of the abnormalities are. I mean, it's up to us to interpret the scans and, could there be some infection somewhere? Could there be a dental issue? Could somebody, incidentally have a thyroid gland that's overactive? We see that all the time. But if there's 3 bone lesions and we biopsy one of them and it's cancerous, then, you can presume that the other 3 are also part of the disease. And also, I'm sure that you use these tools as well. It's what's going on otherwise. Are there other symptoms and signs? The CT scan shows multiple bone lesions. Is there pain? If it's painful in those 3 spots, probably something serious going on. If it's accompanied by a rising PSA, where there's smoke, there's fire kind of thing. So, yeah, it's all in conjunction. It's not just, one simple thing. When we started practicing almost 20 years ago, really all we had were CT scans and bone scans. Now we have advancing imaging studies and different technologies. What are your thoughts on PSMA PET scans, their value? Is that something that you will order for patients? Because very frequently patients will ask me, okay, I got a CT, I got a bone scan, my PSA is up, my urologist says it's definite. Should we add a PSMA PET scan to the workup? And how do you answer that? How do you go about that question?
Yeah, a very common question. I face the same question all the time. That, hey, do we need to do a fancier scan? I heard that there's this scan that they do in Mayo Clinic or this scan that they do wherever, And it comes up a lot. I would say at least when somebody has metastatic prostate cancer, which I think is what you're getting at, Tom, with metastatic prostate cancer, at least the first scan, I'll try to get one of these newer scans done. So either a PSMA scan, so a PSMA PET scan or PSMA scan, or a PET scan, general PET scan done, just to kind of maximize sensitivity that we know where there may be abnormalities within a patient's scan. And this will, of course, hinge one of these, real life things, real practice things. It'll hinge on insurance naturally. So the insurance may or may not approve it. And like I tell my patients, that I'm sure, most of us will tell our patients that, hey, let's make sure the insurance approves scan X or Y, just so they don't get some big bill, because these scans are not cheap if it's not covered by insurance. So I tell them, better to just make sure that we do the right scan as far as that's concerned. But I do try to get one of these newer, fancier scans, either a PSMA scan or a regular PET scan, FDG PET scan, as one of my 2 most common initial diagnosis scans, just to maximize knowing what do I know from head to toe in the patient as far as what where the cancer may be affecting their body. Now, for subsequent scans, I may not necessarily repeat that same type of scan. That'll depend on different factors, but at least the first scan, that's how my approach is. I don't know if you feel differently, but that's how I like to do it.
Yeah, I agree. And sometimes I like to have somewhat of repetitive studies, CT bone scan and the PSMA PET, because you don't necessarily know how it's going to be best to follow the patient moving forward. One scan may give you more information than the other. Also, you might go to scan number 2, 3 months, 6 months down the road, and insurance denies the fancier test. So it is nice to have both because with different imaging modalities, the radiologists pick up on different things, and sometimes you can be misled. If you have a PSMA PET scan first and CT scans, then you have flexibility in how you follow the patient.
And one thing, if I can add, Tom, I've had a couple situations like this, you may have as well, that they've had another malignancy in their history. So then it becomes, well, they have prostate cancer and they have a history of whatever else. So I have a patient of mine currently who has prostate cancer, on treatment, doing well, luckily, but also has a history of sarcoma. And the sarcoma has been treated with surgery, radiation. It was a big process for that sort of thing. So the patient kind of needs following for both. So I'm sure there's people out there listening who may wonder about, like, well, they have a history of other cancer X. So what do I do? So in that case, what I've done, at least for a few patients, is that I've alternated every 6 months or, every other scan, PSMA scan, then a regular FDG PET scan, and then gone back and forth to try to say, well, this way, because if we check a PSMA scan only, we're going to look for PSMA avid disease, prostate-specific membrane antigen avid disease. So meaning that cancer lesions that express that particular prostate cancer protein. But if it's a sarcoma or lung cancer history, then those are not going to show PSMA, and you don't want the patient to miss proper monitoring of the other cancer in their history. So every so often these cases come up, and they can be, a little bit of a diagnostic challenge, obviously, also, like, how do we best sort of balance everything out?
Yeah, yeah. All right, so switching gears a little bit. Typically, after we have the discussion regarding diagnosis, staging, describe what metastatic disease is, that sort of thing. Very frequently, the next question I get is centered around how aggressive is the disease. Patients ask, can we tell how long I've had it? How long do I have to live? And obviously, those are questions that, to you and I, you can't necessarily answer them right out of the gate. There's a lot that feeds into those sort of things. But what are the kind of factors that you use that help to influence your sense of overall prognosis? How aggressive is the disease? How quickly do you have to jump on it? How many, different treatment modalities do you have to consider?
Yeah, a great question, and it's always, like, the crystal ball kind of question. Like, okay, what do we tell the patient? And I would say, just to share with patients out there, is that this also becomes, we have to think about this as doctors, as oncologists, that, okay, how do we put it together? I want the patient to know, obviously, what is the real deal, what's going on, but at the same time, how do we frame it in the right way for their particular case? And obviously, these things vary quite a bit, quite dramatically, patient to patient. We have some cancer patients who do great for years, other patients who are sadly on a much more aggressive course. And so a few things that I used to look at, just a few, big high level factors. One is, do they have a lot of metastatic lesions or just a couple? So a lot versus a few sort of makes sense, more cancer bad, but it also has shown in studies and that kind of thing that prognostically those patients do worse if they have several lesions. And when we say several, we typically mean 4 to 5 or more metastatic lesions in the setting of prostate cancer. That's number one. Number two is the Gleason score. So even in metastatic disease, Gleason score does matter prognostically. It won't necessarily change the treatment necessarily, but prognostically it'll matter. So if a patient has a history of Gleason 9 or Gleason 10 prostate cancer, even Gleason 8 for that matter, but those kind of higher Gleason scores, then those Gleason score cancers do have a worse prognosis.
So, Amit, what do you tell patients when they ask you about their PSA level in the metastatic setting?
Yeah, great question, because patients always ask about PSA, which, by the way, is very valid, because the PSA, as much as it gets kind of like criticized sometimes in the medical field Sometimes I see it in news media even. But the PSA is the best easily available biomarker, lab test biomarker we have to say, well, let's have some quick look. How is it doing as far as responding or not responding to treatment? So the way I frame it is that the PSA, control of the PSA, or a quote unquote normal PSA or zero PSA isn't necessarily the goal with prostate cancer therapy, with metastatic prostate cancer. We want the PSA to be heading downwards, and there is value that the low as we can get it has prognostic value. So patients historically who have a PSA that does become undetectable on the PSA test, those patients do prognostically do the best in terms of staying stable on whatever treatment they're on. So there is value in that. But one key point is that our goal is not PSA. If the PSA does not get down to zero, it's okay as long as everything else is stable. Because the metastatic sites, the metastatic lesions on the scan, those will endanger the patient's health and life, not the PSA in and of itself. So kind of related to that is, I often get a question, perhaps you've had the same, where they say, well, what's the highest PSA you can live with? Or what PSA level becomes dangerous? That kind of idea. And like we always tell our patients, well, there's no such number. It's not like some number max kind of situation that becomes dangerous. But that being said, the higher it is, something bad is happening, unfortunately, in that patient's case. Because if the PSA is 1,500, 1,500, the cancer is not controlled. I mean, there's no way that patient's cancer is controlled. There must be really active prostate cancer going on. If the PSA is several hundred, definitely 1,000 plus. So those are some of the ways I kind of frame it.
Sure.
And I can expand on that if you want, Tom.
Yeah, no, I agree 100%. We can't look at a patient with a PSA of 40 and say that they have a better prognosis than a patient with a PSA of 60. It doesn't work that way. Everybody's cancer is a little bit different. How much PSA their cancer excretes, is a factor. But on broad levels, if a patient has a PSA, generally, lower PSA is better. But if PSA that's truly very, very high, as we would describe it, sort of off the charts, it obviously indicates, an untreated advanced disease. And that's not to say that they won't respond to treatment. We've all had patients with PSAs of, 800, 900. I have a gentleman I'm treating right now, came to me with a PSA of almost 900, lots of disease, way more than 5 lesions. And within a couple of months, his PSA was dramatically lower. So,
yeah.
PSA down to 10, a couple months later down into, less than 1. And that's, he wasn't previously treated. So it's really a barometer. Which direction is it going in? Is it creeping upward? Is it creeping downward? It's more important to us that it's heading downward or stable than it is actually achieving an undetectable PSA or necessarily having, a certain number that we're targeting.
And one thing real quick is,
Yeah.
I do tell patients that, similar to what you said about the example of your patient, that even if it's the PSA several hundred in terms of its level, 500, 600, that doesn't mean the PSA won't get down to super low levels, even undetectable levels. That is still a realistic possibility, not a guarantee, but a possibility that the patient might respond really, really well to treatment. Now, anecdotally, I would say that when the PSA has been above 1,000, I typically don't see the PSA go down to undetectable. But like you said, Tom, that may be okay in a general sense as long as the overall cancer is stable. So, but just to share that is that usually if it's over 1,000, I tend not to see it go down. There might be like 1 or 2 cases I've had, but even if it's like 500, 700, 800, I've seen patients who go down to undetectable and even stay undetectable for years. Not cured, but just stay undetectable.
So we've been talking about patients with metastatic prostate cancer, meaning that they have tumors that we can see on scans and otherwise that indicate that the cancer has spread elsewhere. Just as a side note, as a caveat, there are patients that you and I see, that oncologists see, where their cancer is reoccurring and their PSA is rising. We do not yet see actual cancerous lesions on their scans. The patients will have a PSA that used to be 0 after their prostate was removed or down to very low levels after radiation. And then it starts to creep up. PSA goes to 1, PSA goes to 2. And I very often have patients ask me, well, I've been under the impression that as long as my PSA stays under 4, that I don't have anything to worry about. And how do you address that question? Because that's a very specific situation where us as oncologists start to worry.
Yes, exactly. I mean, and also a common question or common, I guess you can say, misunderstanding in a sense, and I often will then try to frame it to, for the patient that, well, I know where you're coming from. The idea of a PSA less than 4 is, I believe, what you may have heard from your general physician, your primary care provider, that the normal PSA value on a blood test will be a PSA less than 4. So that might be what you're thinking about. I might tell the patient something along those lines, And then I say, but in this situation, once somebody has prostate cancer, if you've had prostate surgery, for example, so the prostate's been removed by a prostatectomy, then if the PSA is now going up, that less than 4 range goes out the window. Now we have a different aim as far as what is considered concerning versus okay. And so, like you said, Tom, if the PSA was undetectable after prostatectomy, for example, or radiation therapy, some low level, and now it's creeping up, that is worrisome because at that point, the cells that are making PSA protein, unfortunately, are very, very likely to be prostate cancer cells making that protein. So that less than 4, but I try to frame it for the patient that you may be thinking about the less than 4 from your primary care physician. Maybe that's why you're referencing that. Unfortunately, this is a different situation, and then I will kind of explain it that way.
Yeah. Again, it's back to the trend. Once somebody has prostate cancer, it's no longer the number specifically that concerns us. It's the trend. If you had a PSA that was 0 after your prostate cancer was removed, Gleason 7, Gleason 8 prostate cancer 5 years ago was resected, and now your PSA, even 0.5, will get our radar immediately up. That something's probably cooking somewhere. And no, the previously understood, concept of a PSA needing to be under 4 before a patient had to worry is no longer applicable. So one of the big things I want to talk with you about is treatment, but before we get there, patients will often ask me, because they have a lot of concern for their family members, is this a genetic disease? Does my family need to worry about it? Should I get genetic testing?
Yes, and a very valid question. Any patient will have these general, almost life philosophy kind of questions like, hey, why did this happen? Did I inherit this? Is there something that runs in the family? These are very understandable, very human questions, I think, how people will try to process the fact that they're dealing with such a, life and death diagnosis. So the answer is, at least what I tell patients, is that the prostate cancer can be hereditary or can be genetic, but only in a minority of cases. So when we say a minority of cases, at least what studies have shown, when we look at different genes that can be inherited that lead to prostate cancer risk of development, the number of people that have such a gene is, studies say, about less than 20% that have any of these genes. The most common gene is one that a lot of people may have heard of out there called the BRCA gene or BRCA gene, and especially the one that's called BRCA2. So this is one common gene that can cause DNA damage to happen much more readily, and that can lead to cancer developing because normal cells, then DNA damage, become cancerous cells. That's the general, very high level kind of process by how these cancers develop in the first place. But so it can be hereditary, and it is worth checking. In metastatic cancer cases, nowadays, I promote or I advocate for, hey, let's check and find out, because it can help influence therapies that we will prescribe for you, the patient. Number one, that didn't used to be the case several years ago, but now we have a lot of data and therapies approved by the United States FDA that we can have therapies that can work better if somebody has such a gene mutation, that we can help treat the patient better. So that's number one. And secondly, if we know a patient has a hereditary case, that can be very useful for patient counseling for their family. So it can be directly related to maybe brothers or sons, but also depending on the gene involved, there can also be risk for female relatives. So for example, the BRCA gene, along with prostate cancer, has risk for breast cancer and ovarian cancer, for example. So both sons, daughters, etc., siblings can all be potentially receiving useful information if there is such a gene found in that particular patient's case.
Yeah, that's right. Very good point. A female having a female cancer like a breast cancer or ovarian cancer doesn't necessarily mean that their genetic disease only puts other women in their family at risk. Same thing with men and male-derived cancers such as prostate cancer. If there's a cancer-causing gene that led to their prostate cancer, doesn't necessarily mean that only the men in the family are at risk. So it could have broader implications. Of course, you and I both know, a lot of people may not know, there's also an increased risk for pancreatic cancer with a number of these mutations, and of course, that can affect anybody. So, there's broad implications. It's not just, oh, I don't have any sons, so, we don't have to worry about it. We'll talk a little bit more how this impacts treatment because genetic testing is now impacting that as well, not just, familial risk for who's at increased risk, but also, what treatments we might have available. So, getting into treatment. So, most patients know that the mainstay of prostate cancer treatment is hormonally driven. And so these patients come with already a general sense that what we're going to do is suppress their testosterone. So when we first went into practice, 15 to 20 years ago, we basically had essentially one option. All patients received Lupron or similar medication to suppress testosterone levels, often in combination with bicalutamide for the first month. And now things are advancing. So we still have Lupron, which works very well.
Mm.
But now we have oral agents such as Orgovyx. We have other hormonally driven agents that we add to these drugs. So when you see a patient who first presents to you with metastatic disease, how do you make the decision what hormonal therapy to start them on?
Yeah, and a very good point about how treatment has changed over the past just 20 years in a very good way, that we have more options and more ways to attack the cancer. So that's one big picture idea I like to tell patients about, that we know more and we're able to attack the cancer by multiple ways that we didn't have before. It's not just like one path and that's it. That being said, because a lot of my patients will come in, as you say, they might expect that, well, their testosterone is going to be low. I'm not going to be happy with that. Low testosterone, that doesn't sound good, and everybody hears the between advertisements and friends, it's of course a rage nowadays. I don't blame them. I mean, low testosterone, they're going to have symptoms. So, but that being said, I tell them, look, for prostate cancer, when we're dealing with cancer, we're dealing with literally life and death diagnosis, just the reality of it. So the best treatment that's going to give you the best mileage, over hopefully several years, is going to be testosterone suppression. So I sympathize with the patient. I hear them 100% that I don't want them to, have the symptoms of low testosterone. But in terms of fighting the cancer, that will be the treatment that gives them the most mileage up front. So that's why when I'm sure you get this kind of question that, well, do I have to do it this way? Does the testosterone have to be so low? Something along those lines. And I tell them that this is the best that you have.
And we also get the question, can we go on and off of treatment? If my PSA goes down to zero, can I take a break?
Yeah. And I usually tell them, especially, let's say, for example, the PSA went to zero 12 months into treatment. So they're 1 year into treatment and the PSA is zero. And then they say, well, can I take a break now? And I tell them no. And it can admittedly be not the simplest conversation. I have to kind of like sit down with them. You have to really talk to your patients. That's one thing I like about oncology. I think when we go into a field like oncology, we really get to know the patients. So it's kind of, I think it's a nice thing for us also on that kind of, physician humanistic level. But I have to tell them that, look, the cancer is doing great, but the deal with cancer is we have to keep it under control. This is a bad disease, aggressive kind of condition, unfortunately. And yeah, you're doing great. You're on the right path, Mr. X, Mr. Smith, but let's keep it suppressed. And then we can talk about it down the road. I'm open to ideas, but for the time being, especially if it's relatively early on in the treatment, like within the first few years, I would strongly advocate for saying, yeah, I hear you, I sympathize, but we got to keep this testosterone at least in the minimum the less than 50 level on the blood test. So it doesn't have to necessarily be super low, but at least less than 50 on the blood test.
Yeah, we know the data clearly shows that patients who stay on continuous androgen deprivation have a better prognosis than men who don't. We all also have patients who refuse to be on continuous androgen
Yeah.
deprivation. And part of it's working with your patient. I mean, yeah, you have to meet them where they're at. Certainly better to have somebody on intermittent therapy rather than no therapy at all. But I strongly encourage my patients to try and stick with it because they will statistically live longer if they remain on androgen deprivation. And not just as their initial line of therapy, but as we all do, as a standard of practice, as an adjunct to whatever other therapies we are adding along the way. Continuous androgen deprivation, plus chemotherapy, plus radiation to symptomatic lesions, plus whatever else we're doing, really does improve prognosis. So what is your standard practice with adding additional hormonal agents up front in the metastatic setting? Patients, in your community and mine, very savvy, very well read, so they know there's drugs like darolutamide, apalutamide, things that we add to, a Lupron or an Ergovix.
Yeah. So what I tell them, and it's a great question, Tom, because patients might have heard from maybe other physicians, maybe people they've talked to, that, well, the hormone therapy injection alone is enough, Luprolide or one of these kind of therapies, So, and the data, we have multiple large phase 2 randomized trials over the last, 5 to 6 years that adding one of these modern pill therapies for preventing testosterone from stimulating prostate cancer cells, adding one of these modern pill therapies plus the injection, the hormone therapy injection, clearly does better in terms of patients having a much better chance of staying alive over several years. So one of the things I talk to patients about, sort of selectively as far as how deeply I'll go into it, will be our National Society guidelines, the National Comprehensive Cancer Network guidelines, or NCCN guidelines. And on the NCCN guidelines, there are 3 of those therapies have category 1 or top level recommendation. And these are abiraterone, apalutamide, enzalutamide are the 3 top level ones if you just give a pill with the injection. So that's like the most current one as of, January 2026. But so I tell them that, okay, just add one of these therapies with the injection. This will maximize the chance, your odds of staying alive 3, 4, 5 years later. And now we can realistically expect with modern therapies like the ones we're talking about that they can stay alive for 4 or 5 years later. The majority will be alive. We used to not be able to, when we started practice, we could not say that in terms of the majority being alive. Now, the majority, meaning more than 50%, will be alive 4 to 5 years later with these modern pill plus injection combinations. And that's nice to see and nice to tell a patient.
And one of the other things that's really changed dramatically is the role of chemotherapy, both in the sense of using it less and maybe using it more. When we first started practicing upfront hormonal therapy, essentially single agent Luprolide, once that failed, you would put a patient on chemotherapy, docetaxel, cabazitaxel, these drugs. And now we have treatments that, for many patients, will extend the period of time before a patient needs to go on chemotherapy. But there still are some patients where chemotherapy up front can be beneficial. And I very commonly get the question, should I have chemotherapy? Some patients don't want to be overly aggressive because they're worried about side effects. Some patients, want to run through the brick wall and tackle it, right away. So, what patients do you consider for chemotherapy in the initial setting while you're doing these other hormonal treatments?
Yeah. And you put it in a great way, Tom, that nicely we can use chemo selectively in a way more for the right patients. But at the same time, we can also sort of use it less, broadly speaking, because we have more types of therapies that can work. So we can postpone. Before, as you said, we had to give the hormone therapy shot, and that was the best first treatment, and then chemo will be next. And we didn't have too many other ways we can sort of maneuver at that point in the patient's case. But now, if a patient comes in, and I have this all the time in practice, is literally every week probably, patient says, well, hey doc, I don't want chemo. I don't want to do it. I heard bad things, and it's like, look, the patient, you're the patient you're living with this. It's your life, your health. So I'm not here to put them through this if they don't want to do it. And, chemotherapy, of course, is no small undertaking. So the patient has to be willing, obviously. They have to be on board with it. Some people want to go through the brick wall, as you said, and do it. Some people don't. So one thing is that, hey, what's your willingness to do it? And also, are they medically appropriate? I mean, we have some prostate cancer patients who are in their mid to late 80s. How we'll think about their case in terms of what is medically safe and realistic will be different from the patient who's 68 years old. So that's one level. Second level is that, who do I think, as you said, who do I think about who may benefit from chemo early? So very broadly, three big situations. One is a patient who has many metastatic lesions off the bat, right from the beginning. So if they have 6 bone metastases and lymph node mets as part of their case, that's one situation. Second case is that a patient who has metastases that are affecting other organs, especially the liver. So if there's a patient who presents, initial diagnosis, we see the scan, and along with bone, lesions and lymph node lesions, there's also liver metastases, liver lesions. That patient also will typically think about being more aggressive, chemo early, to maximize the chance the patient has. And the third big situation, I'll think about chemo early talk to patient about chemo early, will be somebody who's very, very symptomatic from their prostate cancer. There are some patients who have prostate cancer that have surprisingly few symptoms. I mean, there are some patients who come in, I'm curious what you think, but they're surprisingly, in spite of metastatic disease, they say, oh yeah, hey doc, I feel okay. I'm a little bit tired, but it's not bad, And other people who are very, very symptomatic, bone pain especially so. And those are the three most common situations where I'll tell a patient, yeah, you might benefit from chemo early to maximize the chance we can knock the cancer down and get you on a better path going forward here.
I agree with all that. The first thing that I'll say is that, you touched very nicely on addressing goals of care. It's not one size fits all. The textbook says one thing, textbook, nobody, it's all a compilation of clinical trials, but nonetheless, the textbook says do it this way, not always the right way, depending on the patient. There's patients who really don't want to endure chemotherapy, even if it's for a limited time at the beginning of their treatment. There's patients who've had families that have gone through chemotherapy and not had good experiences, which unfortunately happens. And then there's a preconceived notion about how all patients, experience chemotherapy. But then we also have our sort of hard clinical indications. And without question, for me, the single strongest reason to give chemotherapy early on is if there's involvement of the organs. We call it visceral involvement, but any sort of organ involvement. Symptomatic disease, yes, there's other ways we can go about that. We'll talk in a minute about radiation, but there's other ways that we can tackle symptoms, bone pain and stuff like that, genitourinary symptoms, because, maybe the patient didn't have treatment for a localized disease initially. Maybe they presented with metastatic disease, never having been treated in any fashion. But it can improve prognosis for patients who have these more aggressive disease. Usually, the unifying factor, going back to something we talked about before, is a high Gleason score. Typically patients will have, Gleason 9, Gleason 10, if they have terrible pelvic pain, if they have liver involvement, if they have lung involvement. Usually it's because they have a high Gleason score. So they fall into this category of a higher risk metastatic prostate cancer. And one of the important things for patients to know is that if we give chemotherapy early on with docetaxel, it's limited. They're not on chemotherapy for the rest of their life like patients are if they have metastatic colon cancer, metastatic breast, things like that. we would give them chemotherapy for approximately 4.5 months. And it's just we call it debulking the disease, knocking the disease down, gives us kind of a head start. And then their treatment would evolve into what we had been talking about before, where it's hormonally driven, leuprolide, plus these other oral drugs. And that would be more of the long-term, treatment plan after we hit it up front with some chemotherapy. Some patients, though, with a lower Gleason score, maybe we think based on all the factors that we talked about before that it's not that aggressive. Even if they would be a potential candidate for chemotherapy, sometimes I'll hold off, because I know maybe I could get them many years before we have to undergo those potential side effects. Maybe they have diabetes and they're at higher risk for neuropathy. Well, there's lots of different reasons, but it's definitely not one size fits all. And it's a discussion with your oncologist. And there's a lot of factors that we put into it, trying to sequence it, trying to play the hand we're dealt, so to speak, with the tools that we have available.
And broadly speaking, because we have more treatment ways we can attack the cancer, if the patient doesn't want chemo or they're not a great candidate, medically speaking, to receive chemotherapy, we don't have to do it. We have other ways we can effectively deal with the situation, even without having to go to chemo. That flexibility that we have now that we didn't have several years ago.
So a couple things that I just want to touch on. Patients will ask me, can we just, surgically remove metastatic disease? Of course, the answer is no. We don't even have to belabor that. Radiation is a big treatment option for patients with localized prostate cancer. How do you use radiation in the metastatic setting?
Yeah, so for metastatic disease, and you said it right, is that unfortunately when it's metastatic and, it may be medically obvious that, well, unfortunately we can't just like surgically remove these spots, even though it may not on the surface, in a lay person sense sound illogical, but it's just not medically possible because the cancer's already spread. So that's fundamentally the problem. But as far as radiation is concerned, the most common way I'll use radiation in a metastatic case will be a patient who has pain at a given bone spot. So in one bone, let's say one of the vertebrae, one of the spine bones in the back is having pain, and there's like a metastatic lesion there that we know is there on a scan, then we could give so-called palliative radiation to that area. And often this kind of radiation is given just for symptomatic control, will be just 1 week. So meaning like 5 treatments, once a day, Monday to Friday, and that's it. That's typically all that's needed. Maybe a second week, but often 1 week is enough to give them that kind of symptom control, this sort of zapping that spot for a patient who's having symptoms there. So that's the most common way I'll use radiation. Second way I'll use radiation in just a minority of patients that, let's say they have very limited metastatic disease. So they're metastatic in the sense that there are bone lesions elsewhere in the body, no visceral metastases, so no organs that are affected besides the bone. And then if it's very limited bone lesion, just like let's say a couple, and they're both in the pelvis, for example, in the pelvic bone, then we could selectively use radiation just to that area to try to address that limited metastatic disease. Now that's it's selectively done, but there are studies behind it that we could do it that way for the patient with limited metastatic disease and trying to achieve a so-called NED or no evidence of disease state where they're sort of in a remission, though we don't say that they're cured, but at least we've achieved sort of like maximum control of the metastatic prostate cancer. But again, that's in a patient who has only limited bone mets, not if they have like 5 different bone mets, you can't give radiation to 5 different spots. It's just not a realistic kind of thing. And I say that because you'll hear stuff that's out there on the internet nowadays. Well, now they can zap, 6 lesions if they want, or 7 lesions. I've heard all kinds of stuff out there when you're kind of like just curious as a physician and just like, going on YouTube, the kind of stuff you hear out there, there's a lot of noise out there, I have to say. So you want to do things that are kind of realistic, that you actually have a chance of getting benefit from. You don't want to go the cowboy route too often because it may be a lot of extra stuff the patient has to go through with virtually no chance of really having benefit,
Yeah, you have to be careful because there's things that you can do, but not necessarily things that you should do. I mean, painful lesions, I think, is very straightforward. Radiation is a great tool for us to deal with any type of cancer if it's a painful lesion. And I agree with you. I mean, I will treat a couple of, oligometastatic lesions, single or maybe, two, if I can render a patient, you know, radiographically free of disease. By that meaning their scans don't show any evidence of disease. I think that that's an accomplishment, if nothing more psychologically. But we can't spot weld the patient and, hit many spots and achieve anything meaningful because you're not changing prognosis. If the cancer is in 5 or more places that you can see, it's in 5 or 10 other places that you can't see. And so, to try and hit them all with radiation doesn't change a patient's overall prognosis. We had talked earlier about genetic testing and how it applies to the discussion about family, and you had touched on how it guides treatment decision. Doesn't really guide our decision with initial treatment, but it can guide second line and further line treatment. Can you explain a little bit more about the genetic testing? And then now there's something that we're doing in oncology. Almost all patients, next gen sequencing, I phrase it to my patients as molecular testing. We're looking deeper. The pathologist tells us, okay, you got prostate cancer. Now we're sending these tumors out to reference labs, and they're doing more sophisticated testing, which has given us additional information.
Yeah, it's very interesting how this has evolved, this testing, and then how that can guide our treatment recommendation for a patient is very interesting how that's evolved over the past few years. So, very correctly, the way you said it is that it may not change our upfront therapy, but it will be part of our strategy going forward later in the patient's case. So, number one, the one reason a patient should get tested, from a physician recommending to a patient, should get tested is that it'll be a very clear cut if they have a gene mutation, if they have one of these genes that are part of these various ones that are known, it'll be a very clear cut yes or no answer. Like, do they have a mutation or not? It won't be a guessing game. So that's what's nice to tell a patient, hey, let's get it tested. We'll know very clear cut DNA testing by the different, sophisticated methods that do you have it or do you not have it? If you don't have it, okay, now we know we can move on to other strategies we might think about for that patient. If they do have it, great. Now we have one more option, one more path by which we can potentially attack the cancer. So the nice thing is that there's no guessing involved. You will clearly know if you have it or don't have it, and it might open up one more door in terms of one more therapy avenue for that patient. So that's big picture why it's really nice for us how we can get it done. Now, how it gets tested, a lot of patients wonder, well, how do I even get this kind of information known? So either it'll be done classically by a tissue biopsy, so needle biopsy, get cells, the cells get tested by the different labs that are out there, national labs that are out there, and you can get it done that way. But there's also a way to do so-called liquid biopsy, which is sort of like a misleading, terminology in my view. But basically it means like a blood sample. Now, the one caveat I tell patients with a blood sample compared to tissue is that there's a more chance of having a false negative. So it looks like they don't have the gene mutation, but the blood sample might have missed it if they didn't acquire enough cells in the sample. So ideally, we get it done off of a tissue specimen, meaning from a needle biopsy would be the most typical way we do it. So that's how we get it tested. And then very, very briefly, I'll just mention, Tom, is that so then if a patient does have a mutation that's among these various genes that are known, then that can help influence or, shape our recommendation for the patient. Hey, if we get this therapy that attacks the testosterone pathway and a second therapy that targets the genetic, mutation abnormality, then those things can synergize and get real mileage, more mileage than they would have gotten just from the testosterone affecting therapies alone. So there's a big upgrade they can get that they wouldn't otherwise be able to get by getting the mutation targeting, the DNA targeting therapy, along with the testosterone pathway therapy together, they'll get much more mileage. And that's one of the breakthroughs in the past just 3 years in prostate cancer. Those combination therapies weren't known because the trials weren't done until a few years ago. Then now we can synergize those therapies and we'll nicely be able to know very straightforward, do they have it or not?
Yeah, it helps patients to get more mileage. We're adding additional treatment options in the middle, instead of go from treatment A to treatment B to treatment C. Well, maybe we stick D in there somewhere. For patients who didn't originally get chemotherapy, it prolongs the time until they need chemotherapy because we have other options. Most of these drugs are oral drugs. Occasionally, we have, other options, immunotherapy, that's less common. But all of this is improving our ability to prolong patients' life, and for the most part, doing it with treatments that have, relatively fewer side effects than some of the more aggressive things that people worry about, multiple chemotherapy agents, things like that.
Yeah, if I can say very briefly, Tom,
Yeah.
these are pill therapies. So that's one thing patients like. Is that okay? This is what we're talking about. It may be an additional pill, but they're pill therapy. So that's often palatable to the patient, so to speak. That okay, it's not like I'm coming in for chemo suddenly. That's number one. Secondly, is that when we talk about extra mileage they're getting, we're often able to the average time of getting one of those therapies and delaying the time to needing their next therapy will be 2 years plus. So 2 years of time on one of those mutation targeting strategies, it's not a small amount. It's not just a few extra months, but a couple years on average. So that's a nice thing also.
Yeah, very meaningful. Just as a quick comment on the liquid biopsy, which has really helped our ability to gather this information. Um, a couple of situations that we face, patients would say, well, why do we have to resort to liquid biopsy? One is that their original prostate cancer diagnosis was so long ago that it's almost impossible to get tissue from their original biopsies. And second, along with that, is maybe they're in the situation where they have relatively small amount of metastatic disease, small volume disease, biopsy is difficult or impossible, or it's of a bone lesion quite commonly, and oftentimes that doesn't yield enough sample for us to work with. So we're left frequently with the only option being a liquid biopsy. But as we go along in a patient's treatment, it used to be you get your biopsy, you start your treatment. If they need one treatment, two treatments, five treatments, you rely on that original biopsy that you had sometimes years ago to make all your decisions. Not the case anymore. We had a biopsy on a patient 10 years ago. Now we have a liquid biopsy, today. Maybe a year or two from now, we're going back to, a lesion to try and actually get tissue. Maybe we're repeating the liquid biopsy because treatments change, information changes. It's not, we're not looking at the disease in the sense that it's all, the same homogeneous disease. It can be heterogeneous and change over time. So, patients will frequently get multiple biopsies, will repeat biopsies, multiple liquid biopsy samples so that we can try and get more and more information. Sometimes at each, time we hit a fork in the road, if a patient's fortunate enough to be on treatment for 2 years, we may go all the way back to the drawing board before we make a decision on what our next treatment would be, rather than rely on the data that we got a couple years ago.
Yeah, very well said.
So the last topic that I'd like to talk with you about is managing side effects. We've talked throughout the whole discussion about the typical side effects. With hormonal therapy, the big concern is fatigue, muscle mass decrease. Men are very concerned about sexual health. Everybody's concerned about it. But, erectile dysfunction, mood, that sort of thing. How do you counsel patients on these side effects? How do you motivate them to stay on treatment when they're having a difficult time?
Yeah, and it is a real challenge because on one hand, we can get way more mileage than we used to be able to get, where people are alive for several years, even with metastatic disease, advanced prostate cancer, and yet the patients are really putting up with these side effects, Tom, as far as what they're having to deal with. They're the ones going through it and taking a pill, and testosterone is low, prostate cancer is controlled, but they're having symptoms. So it's often tough. I think that one thing is there's a lot of counseling I feel up front in terms of a little bit of saying, hey, by the way, you'll get through it, you'll get used to it. Used to it meaning that it won't feel as bad as time goes along. Initially the change going from, let's say, a typical man that may have a testosterone level, let's say 500 or something like that, to 500 going down to less than 50 is like a big drop abruptly on a therapy. So that change is where people feel the most. I say, look, you've gone through a big change here. That big change will make you feel not so great. But as time goes along, I give the analogy of like a diet that, okay, when you first cut out like sugar from coffee, it'll taste really bad. But after a while, you don't notice it anymore. You kind of get used to it. So I say it's kind of like that, not to make light of it, but it's kind of like that you will kind of adapt to it, number one. Number two is that people often ask, like, well, what about stuff like erectile dysfunction, and will that happen? And I say, yeah, I mean, that can happen, both in terms of libido as well as erectile function. Both of these factors can be affected by simply having low testosterone intentionally on the treatment, but these are some of the side effects, like you mentioned, Tom. And so my philosophy is, at least as a physician, is that if they want one of the, different pills for erectile dysfunction to help them out, that's okay. Medically, that's often okay, depending on what their other, comorbidities are outside of the cancer side. But that is okay also, because at least they can benefit in that way when things like erectile dysfunction are maybe affecting their life, obviously.
And how about a lot of questions center around supplements and diet? Patients very commonly want to know when they have a cancer diagnosis, should they be making changes to their diet? Should they be taking supplements, vitamins? Well, on two sides. One, they want to know, will any of that help their treatment? And then, of course, a lot of patients are already on various supplements. They want to make sure that they're not hurting their treatment or doing things that are going to interact with the stuff that we've prescribed. So what is your typical recommendation when a patient comes to you and says, should I go on a diet? Should I change dramatically what I'm doing with how I'm living?
Yeah. And I think this is such a common thing in the world of cancer overall. What should I eat? What should I take? And I read a study a couple years ago, Tom, that roughly when they surveyed like cancer patients who were at, I forget what center, but somewhere in America, and they said, well, how many people are you taking supplements to try to help the cancer treatment or your prognosis? Are you taking supplements, but not telling your oncologist, like not informing them? And I think the number was 46% said they do take it, but don't necessarily tell their oncologist. Not because they're trying to hide it necessarily, but they may not share it or whatever the reason may be. So it's happening out there. That's just like, I think you just have to we have to kind of accept that, hey, people are doing it, and I get it. I mean, I think that they want to do something to help their cause. So I think fundamentally that's where it's coming from. And so there's a lot of noise out there, but there are various foods and supplements for different specific cancers that actually have published medical data. So that's something that's kind of not as well publicized or not as well known, but I'll give you a couple of them that I share with my patient with prostate cancer. And I tell them that, okay, big picture, number one is that you don't have to do this. If you are motivated and interested in doing a few supplements to try to help your cause, here are a few things, Mr. Smith, that may help your odds, probably won't hurt your cause, but may benefit. So, and these are things that are, I'll kind of share some of these things that have data, but just to share a couple of them real quick. One is there's several studies for green tea, okay? And there's one particular protein in green tea. That's the medical acronym, the chemical acronym is ECGC. That's just the acronym for the long chemical name. And so basically that's the compound that for whatever reason is active against prostate cancer cells, that has been shown in several studies. And they've had randomized trials in small groups where they've said green tea versus black tea versus water, and which of those, if any, have any kind of, and they've shown PSA decreases, modest PSA decreases. So another key thing I tell the patient as a fundamental concept is that this does not replace your treatment. You can't just suddenly drink green tea and don't take your prostate cancer medicine. This is only at best an adjunct that might help a little bit, might push your odds in the right direction, but that's one. The second one, very interesting. There have been several studies for vitamin D. And there's been several studies, but one big study published as a combination between Harvard, Duke, and UCSF, where they looked at vitamin D levels and prostate cancer mortality. And those people that, intriguingly, and I don't think the exact mechanism of what happens in the cells is known biologically, but patients who have a vitamin D level less than 20, they have like a 4 to 5 times higher risk of prostate cancer specific mortality, meaning dying from prostate cancer. Even among, they all have metastatic prostate cancer. Those that have a even a lower vitamin D level, they have a higher death risk, quicker than those that have a better level. It might point to better nutrition overall, something along those lines. But that's the second one. And there's also evidence out there for things that could cause harm. So one of the things that's also really interesting that I find fascinating as an oncologist is that there are some foods and nutrients out there that have shown evidence of harm in multiple studies. One of the most prominent ones in the prostate cancer world is cow's milk, especially whole milk. So, and I have a couple of them that have been published in recent. This is all published like relatively recently in the past 10 to 15 years. But they looked at one from what's called a physician's health study, and they found that those people that drank whole milk regularly, where they had at least 2 to 3 servings a day, which is not common, I think, in adults in America. But those that do it, they actually had a much higher mortality risk sooner, even all having prostate cancer, but having a higher mortality risk. So there's evidence that milk may be somehow detrimental. The hypothesis is that the protein casein, casein, casein in whole milk that comes from cow's milk, not like normal, like human breast milk for a baby. So that may somehow be potentiating cancer cell growth. It's not exactly known as far as I understand, but so I tell them that, okay, if you're going to do anything, here are a few things that have actual published medical evidence for benefit. One is vitamin D. Keep the vitamin D level up. I figure that, okay, probably not a whole lot of harm by keeping the vitamin D level at least normal rather than keeping it deficient. Number two is that if they want to do green tea, if you like it, great. Drink green tea a few times a week. If you do enjoy it, go for it. Might help, probably won't hurt. And the third one I share is that, well, if you are somebody who drinks, whole milk regularly, maybe try to cut that out of your diet. Maybe they do it via cereal and milk. I mean, you never know. You might not even think about it. You may not be drinking like a glass of milk, but it might be like cereal and milk, and that might be where you're getting the milk content, for example. So there are a few things like that out there that have evidence of benefit. So, and like I said, again, it's not like these things substitute for your cancer treatment. We wish it was that easy, but it's of course not so simple. But people ask for these supplements all the time. They want to know what to do. So at least my mentality is that, well, let me share something that actually has some actual medical evidence where it's been studied and published in peer-reviewed journals. So I'm sharing something that's a little bit more data-based than just random stuff that you might, you read like all kinds of stuff on the internet, obviously, that, you spend a bunch of cash on stuff that's going to have no benefit whatsoever, probably.
Yeah, there's infinite amount of information on the internet regarding nutrition. A lot of it does not have, a significant scientific evidence behind it. So I agree with you. I mean, there are things that are out there that might be helpful, most likely not hurtful. I do not recommend patients have a drastic change in their diet, especially if they're about to undergo things like, chemotherapy and have to manage other side effects. We want to maintain a certain level of nutrition, protein in the diet, that sort of thing. It's not the time to entirely turn your diet upside down. But there are things that can be done that are, reasonably supported by evidence, and they're not enormous changes to a person's, you know, daily dietary intake, and they could be helpful.
That is a great point, is that some people ask about, like, well, should I do a paleo diet or these kind of more extreme dietary changes, which I definitely advocate not doing, because the last thing I want a metastatic cancer patient to do is losing weight, losing muscle mass, potentially, even if they don't lose muscle mass, but if they're losing weight. And caloric intake is a big thing that could help a patient in cancer treatment in their journey. So you want to be careful about that for sure.
And Dr. Amit Mehta also is a editor and chief medical officer of a respected medical nutrition website, FoodieMD. It's all, I think, that perspective is very helpful. Patients always have lots of questions about lifestyle, support, nutrition, those sort of things. Amit, Dr. Mehta, I want to thank you for coming on today. As always, it's a pleasure talking with you. I really appreciate your insight. I hope the patients learn something. Us physicians always learn from each other. So these discussions not only help the patients, but when docs talk amongst each other, it also helps each of us to learn and be better at what we do. So thanks for your time today.
For sure. Thank you very much. Really appreciate the invite. Always great to talk to you, Tom. And thanks for inviting me.